Good morning, everybody. Thank you for possibility to represent next topic. I will represent some data about open radical prostatectomy. Good morning, everybody. In this topic, I will represent some surgical anatomy, open radical prostatectomy technique, and some issues open radical prostatectomy versus laparoscopic and robotic prostatectomies, and some benefits of open radical prostatectomy also. Goals. Main goals is treat localized prostate cancer, to preserve urinary continence and keep well going sexual function, and to control of cancer. Surgical anatomy. Prostate gland is localized in pelvic floor, below urine bladder and anteriorly rectum. Average is about 40 cc, but in some cases could be enlarged up to 500 cc. Venal plexus and blood supply. The superficial branch between puboprostatic ligaments lies outside the anterior prostatic fascia. Communicated branches over the bladder itself into endopelvic fascia. Common trunk above urethra and lateral venous plexus are covered and concealed by the prostatic and endopelvic fascia. Communications with pudendal, obturator, and vesical plexuses in inferior vesical vein. Near puboprostatic ligament, small branches communicate with pelvic side wall muscle and communicate with internal pudendal vein. Blood supply. Blood supplies inferior vesical artery, urethral branches that supply blood and neck, periurethral prostate. Capsular branches on lateral pelvic fascia. Capsule branches identification. Landmark of microscopic plexus nerves. Pelvic plexus nerves are viscerosympathetic, hypogastric, and parasympathetic goes from sacrum from 2 and 4, and some somatic motors. The nerves innervating the prostate travel outside the capsule of prostate and the non-vilea fascia until they perforate the capsule where they enter the prostate. The branches to the membranous urethra and corpora cavernosa also travel outside the prostatic capsule in the lateral pelvic fascia dorsolaterally between the prostate and rectum. Blood supplies of penis, internal pudendal artery, and pudendal vessels can arise from obturator and inferior vesical aberrans vessels divided during radical prostatectomy. Striated sphincter is tuberal, horseshoe-shaped, surround membranous urethra and smooth muscle at the apex, the edges fused in the midline. Slow twitch, passive control, active control, levator urethra, pubo-urethralis, and somatic motor nerves in plexus, Kegel pudendal nerves, levator urethra, and striated sphincter. Open radical prostatectomy technical aspects is control of the deep venous complex, additional hemostatic measures, nerve sparing perform, and vesico-urethral reconstruction. The main operation surgery is different up to 1-2 months after biopsy of prostate, and even more later, about 3 months after TURB performed before. It helps to preserve neurovascular band and prevents rectal injury. Incision in the endopelvic fascia and division of puboprostatic ligaments expose the junction between the apex of the urethra and the anterior surface of deep venal complex, dorsal venal complex. Urethral component of the complex is intact to preserve anterior fixation of the striated sphincter to the pubis. Ligation of the dorsal venous complex. Their goal is to divide the complex with minimal blood loss while avoiding damage to the striated sphincter and interventant and entry into anterior apex of the prostate. A figure of 8 shape horizontal mattress suture of dorsal venal complex, which is then tied. Another on anterior surface of the prostate to reduce bleedings from the proximal dorsal venal complex should be performed also. Division of urethra. Up to this point, the anterior half of the striated sphincter has been divided. Now the posterior component will be released. Division too close to the apex of the prostate may be damage of nerves. The posterior component of the striated sphincter should be divided midway between the apex of the prostate and urethra. Principles of nerve sparing. The neurovascular band is outside the prostate between 2 layers of lateral pelvic fascia, the levator and prostatic fascia. If nerve sparing is performed correctly, the prostatic fascia must remain on the prostate. When the prostate cancer extends through capsule, it rarely penetrates more than 1-2 millimeters. This much tissue is often present even when the neurovascular band is presented. Nerve sparing decision making. The division of blood and nerve, separation of seminal vesicles, intraoperative consideration, induration in lateral fascia, fixation of blood bundle to the prostate. If there is an inadequate tissue over posterior lateral surface after the prostate has been removed, the neurovascular band can then widely excised delayed excision. Anastomosis is performed such way. We perform a reconstruction of bladder neck to make an adequate correlate anastomosis with urethra, and in open radical prostatectomy, suturing nowadays is usual about from 5 to 6. And treatment options for localized prostate cancer depend on multitude of factors, including patient age, take care of, about in opinion about the staging of prostate cancer, and the risk of prostate cancer progression, risk of mortality from the other medical comorbidities, premorbid urinary function, infection, sexual function, and bowel functions. In the metadata, some colleagues have very various decisions. about the possibilities. The base of operation of includes laparoscoping and robotics. Some have and see better benefits various techniques. But anyway, some physicians don't see any benefits for robotics compared to open. But anyway, nowadays robotics radical prostatectomy could perform shorter length of hospitalization, lower blood loss, less early postoperative pain, improved early physical quality of life, and lower blood transfusion rates. And maybe it's better for lymph node dissections and better control of the cancer. Also, it could perform better ergonomic situation for surgeon. But in conclusion, benefits of open radical prostatectomy are such that it's the cheapest technique compared to others. This operation is remains the most common in such hospitals, and with lowest ladders of learning curve, and for example, in our department, nowadays perform about 150 radical open prostatectomy yearly, and about 50 laparoscopic radical prostatectomies, which number increased. Thank you.
Thank you for the presentation. Thank you, doctor. As we see, open radical prostatectomy has its place, especially for the surgeon that works with the laparoscopic. So I think this is the main thing that we need to understand, that what we see during camera, we must feel and then have experience with the during the open repair. So different bleeding understanding, different tissue, soft or hard. So we must understand that it is important for our learning curve. So thank you, doctor.